I'd invite Dr. Sujatha Mohan, who is a very senior and accomplished surgeon from Rajan Eye Care in Chennai, to talk to us on anterior vitrectomy principles. Yes, ma'am.
Thank you, Dr. Haripriya. At the outset, I'd like to thank the organizers and Dr. Haripriya for giving me this opportunity. So my talk is on anterior vitrectomy principles. So what are key components of management of a vitreous loss in a PCR are early and quick recognition of the PCR, avoidance of hypotony, maintenance of a closed anterior chamber, prevention of PCR extension, prevention of nucleus drop, prevention of vitreous traction, and ultimately IOL implantation. So in the case of a posterior capsular tear, there are certain early recognizing signs such as sudden deepening of the anterior chamber, the pupillary snap sign, the inability to rotate a normally rotating nucleus, or you see a sudden tilt or descent of the nucleus. So in this case, the general tendency is for the surgeon to panic. So avoid withdrawal of the phaco probe. Come to position where the irrigation is on but the rest of the parameters are off, like aspiration and phaco. So maintain the foot pedal in irrigation position, and through the side port insert a dispersive viscoelastic. And then once you have filled up the chamber, then slowly you can withdraw. So you are maintaining the anterior chamber stability. That is the idea. If you're going to withdraw suddenly, as you can see in this case, this is from one of our trainers. You see he has started doing IA without realizing that there is a PCR and already there is a nucleus which is dropping. And suddenly he realizes that something is catching on, and in panic he starts withdrawing. See? You just see what happens when he withdraws the IA probe. See, there is an extension and the nucleus is dropped. Because there is sudden hypotony, the nucleus drops. Whereas you see this next case, which is handled by a senior surgeon, he notices a PCR, but at the same time, he's reducing all his parameters. He knows there are a few nucleus bits. So after reducing the parameters, he is continuing to remove the nucleus remnants, but in a very gentle manner, making sure that the PCR is not extending. And you just watch carefully when he has removed his second instrument, his chopper, and he's injecting the viscoelastic before actually removing the phaco probe. So you see the size of the PCR remains the same. It doesn't extend. So that is a vital thing. Then once you have it in position, then you can do a bimanual cortical aspiration. So when to bimanual, I think most of us in the era when we learnt phaco, we were all doing coaxial, and now I think most of them are taught bimanual. So as a routine, they do bimanual. You can do bimanual cortical aspiration. You can do bimanual vitrectomy. So it maintains an anterior chamber. So this is a diagrammatic representation showing very nicely what you do. You can put a dispersive viscoelastic behind the nucleus, just plugging this opening, the PCR, so that it doesn't drop. And then you can either do a gentle phaco, as you saw the senior surgeon doing, to avoid any enlargement, or you come out and do a bimanual vitrectomy, or you can remove these nucleus fragments using visco itself. So this is again another diagrammatic representation where you can see you have used a dispersive viscoelastic to around the area where the small fragments are, and you just do a very gentle phaco. You can even do a dry phaco. The very small remnants, you can stop the infusion if you do a dry phaco. And in that case, you don't enlarge the PCR and you don't allow the nucleus fragments to drop. So bimanual anterior vitrectomy, some of the principles are the AC maintainer should be directed towards angle. I'm talking from an anterior segment point of view. And you make a new side port for sleeveless vitrectomy cutter, lower the bottle height, use the highest cut rate the machine offers. Now you have very high cut rates, even beyond 2500. Lower the vacuum to 100 to 150 millimeters. Use triamcinolone to stain the vitreous. That's very important. Now I think it's medico-legally it's very important that you don't leave behind any vitreous. You have to do good wound as well as anterior chamber toileting. And the vitrector is placed just below the tear, okay, towards optic nerve, but the port has to be pointed up. It is always maintained centrally, so you should be able to see the vitreous cutter, the edge of the vitreous cutter all the time. And So this is again an example of how a bimanual anterior chamber vitrectomy and aspiration is done. So there is a PCR somewhere here, and I'll show you as we start moving towards the case. See, this is the area of the PCR. So once we go near it, see the PCR is expanding in spite of the fact that we are doing a bimanual. So what do we do now? You withdraw, put some viscoelastic, you plug that area of the PCR, and then you re-enter and you can do a minimal anterior vitrectomy. You can stain. Actually this stain has not been shown here, but staining is very important to make sure there are no vitreous remnants. And once that is done, you know there is a PCR, but a very nice anterior capsule is there. So you can inject a multi-piece intraocular lens and you can capture the lens. So that is very critical, because once you capture the lens, the haptic is in the sulcus, but the optic is in the bag. So that's how you capture it. You know the lens is stable. So this is again another case showing a PCR. Patient, the surgeon has recognized, he has come out, is injecting the viscoelastic, and now he's going to convert to a bimanual method. You can see the PCR superiorly. So you just go ahead and do a bimanual IA. Use the area where the PC is open the last, so that it doesn't expand. And now you inject. Every time you come out, you have to inject. And every time you switch instruments, suppose you want to do, see now he's switched the instruments, and the best thing would be to remove the, every time you come out, maintain the anterior chamber. Don't allow it to collapse, so that you can continue without expanding the PCR. You could go ahead and implant an IOL in the bag, a foldable IOL in the bag. So vitreous management, triamcinolone is very important. Avoids cellulose sponge vitrectomy. That is very important, because that can cause anterior vitreous traction, can lead to GRTs. So vitreous cutter should also be used in the wound. Suppose you have something sticking to the wound, you can use a vitreous cutter, but don't sweep the wound like we normally were taught earlier. So this is how you do you stain the vitreous. You can remove all the vitreous by staining it. You make sure that there is no vitreous remnant. And always don't do too much of vitrectomy. You just remove what is required. Just from the anterior portion of the eye, that is anterior segment, or only from the anterior chamber. Don't go inside and do an anterior vitrectomy. That's not required at all. Then you'll make the eye very hypotenuse. Okay, so this is complete. You can see that there is a small tag of vitreous which is being cut. Either you can do that, or you can go through the main port itself. And then you again inject a multi-piece IOL, and again do an optic capture like I showed you before. So fast cutting rate is very important. Low suction and low flow rates. Keep the cutter stationary and avoid very slowly. As you cut, you advance. Do not pull out when the vacuum is on, and the cutter tip should always be visible. So in case of small vitreous prolapse, you can do an anti-vitrectomy, but otherwise the vitreous acts like a slinky. So it keeps on coming out. So a posterior vitrectomy would always be preferable. So through the pars plana vitrectomy, in case you have a very large PC tear, and if you're not very good at doing a posterior pars plana vitrectomy, you can take the help of a senior surgeon, or do as much of wound toileting as possible, and then refer to a senior surgeon. So AC maintainer should be again directed towards the angle. Sclerotomy with an MDR port at 3 to 3.5 millimeters. Vitreous cutter is kept visible. So this is a diagrammatic representation showing how a pars plana vitrectomy cutter works better than an anterior vitrectomy. So this is again a case of quite a large PCR which is close to the section, and the anterior chamber is being stained to find out the area of the vitreous prolapse. And you can see that there's a pars plana vitreous cutter introduced through the trocar canvas system. And at all point of time, you should be able to see the cutter. That is very important. You can't do a blind vitrectomy. So here's, you see this, in this case, the vitrectomy is also done at the area where the vitreous is prolapsed out of the anterior chamber. So through the section. And keep the side port always. Keep either an AC maintainer, or you can use a bimanual method. So once that is done, then you're quite safe, and the dictums are high cut rate, low vacuum, dispersive viscoelastic to dampen out the hyalate phase, cohesive to maintain space, and suture sclerotomy in 20 gauge cutters. So the last slide is, how do you manage in the presence of a nucleus or cortex? In case of whole nucleus, put an AC maintainer, a good complete anterior vitrectomy, place an IOL and do a VR referral. In case of large nucleus bits in the anterior chamber, you can either convert to ECC, or you can do what is called a slow motion phaco, which I already showed you. And what you can do is you can also do a visco removal of these bits. You can just keep injecting visco and then removing them, and do a good anterior vitrectomy, completely clear the vitreous from the anterior chamber, and then place the IOL. In case of small nucleus bits, so you can have to continue with the very important thing is complete wound toileting and toileting the anterior chamber before referring. Placing the lens would be ideal, but if you cannot do it, doesn't matter, you refer, because don't go and try to sweep into the vitreous and produce more complications. So stepwise approach is go bimanual, stain the vitreous, use a higher cut rate and low vacuum, and do pars plana vitrectomy in case of large vitreous prolapse. Thank you.
Excellent talk, ma'am, with a lot of very good videos. I think what goes to show is each case is unique, and how you manage it would depend upon which stage of the procedure you are in. So I think she has to go for another session. So I request, if you have any questions, you can please ask Dr. Sujatha.
Yeah, there's a lens scaffold. I don't have the video on that. You can use it. If you have a half bit or something like that, you can inject an IOL on top of the iris and continue with your phaco and do a vitrectomy. The same principles. Basically, the principle is that
there is a talk on that.
There's a talk on that. So we'll come to it later. This talk is only on anterior vitrectomy, so there are people talking about that. Yeah. So whatever the cut rate, the highest cut rate your machine has, either 2,000, now I think even 5,000. So there are machines which have very high cut rate, because when you cut fast, you get small segments of vitreous. If you have longer segments, there are more likelihood that you'll be pulling on the segments. More likelihood of traction. So traction will lead on to vitreous-based traction, leading to GRT, CME, and all those other complications. So the recommendation is go for a higher cut rate but low vacuum. Doesn't matter. You can use whatever is the highest cut rate that's available.
So whatever your machine allows, go highest in that machine. But vacuum has to be low. That's the main thing for vitrectomy, which will be higher for cortex aspiration.